How does MRD testing change leukemia treatment? How does minimal residual disease testing change leukemia treatment? This question is crucial for understanding how doctors can better manage leukemia. Minimal residual disease testing, or MRD testing, plays a significant role in assessing the small number of cancer cells that may remain after initial treatment. These cells can be difficult to detect using standard methods. By identifying these residual cells, healthcare providers can evaluate how well the treatment has worked and predict the risk of relapse more accurately than traditional methods. One of the key ways MRD testing influences treatment is through risk stratification and prognosis. When patients achieve MRD negativity, meaning no detectable leukemia cells remains, they generally enjoy longer remission durations and improved overall survival. This trend is observed across various types of leukemia, including acute lymphoblastic leukemia, acute myeloid leukemia, and chronic lymphocytic leukemia. For instance, patients with chronic lymphocytic leukemia who are MRD negative after treatment often experience significantly longer treatment-free survival compared to those who remain MRD positive. MRD testing also helps guide treatment intensity. If a patient has detectable MRD after initial therapy, they may be candidates for intensified treatment. This could involve additional chemotherapy cycles, targeted therapies, or even hematopoietic stem cell transplantation to lower the risk of relapse. On the other hand, patients who are MRD negative might avoid unnecessary treatment escalation, which helps reduce exposure to potentially harmful side effects. Monitoring MRD continuously during and after treatment allows for early detection of disease recurrence, often before any clinical symptoms appear. This early identification enables timely intervention, which can lead to better outcomes by addressing relapse at a more manageable stage. Moreover, MRD testing supports personalized therapy decisions. By combining molecular and genetic information with residual disease levels, clinicians can tailor treatment plans. This might involve deciding on consolidation therapies, maintenance treatments, or even enrollment in clinical trials based on an individual's risk profile. In clinical trials, MRD is increasingly used as a surrogate endpoint. This means it can provide early indications of treatment effectiveness, allowing for quicker evaluations of new therapies beyond traditional survival metrics. However, it is important to note that not all residual leukemia cells detected by MRD tests have the potential to cause relapse. Therefore, being MRD positive does not always guarantee that the disease will return. The predictive value of MRD testing can vary among different leukemia subtypes, and ongoing research is needed to validate its optimal use. Additionally, the methods used for MRD testing, such as flow cytometry, polymerase chain reaction, and next-generation sequencing, differ. Standardization of these methods is essential to ensure consistent interpretation of results. In summary, MRD testing transforms leukemia treatment by allowing for a more precise assessment of disease burden. It guides therapy adjustments to improve outcomes and supports personalized treatment strategies. This testing is a vital tool in staging and prognosis, complementing traditional clinical and genetic factors. Ultimately, the goal is to reduce the risk of relapse and improve survival while minimizing overtreatment. Patients should discuss their MRD results and treatment implications with their healthcare providers to understand how this information applies to their specific leukemia type and treatment plan.